Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. This is episode number 22. It's Friday, June 8th. Today we talk about Apple and APIs and what healthcare IT can do about the rising cost of healthcare. This podcast is brought to you by Health Lyrics. Are your strategies constrained by infrastructure, or are you tied in a knot of applications? We've been in your shoes. We've been moving health systems to the cloud since 2011. Find out how to leverage the cloud to new levels of efficiency and productivity. Visit healthlyrics.com to schedule your free consult. My name is Bill Russell, recovering healthcare CIO, writer, and consultant with the previously mentioned Health Lyrics. Before I introduce our guest today, I want to give you guys an update on what we've been doing. So as I shared a couple episodes ago, we've reached some milestones, and what we did is we got together with our sponsor, and what we'd like to do is, now that we have a quality show, quality content, quality guests, we'd like to get into the hands of more healthcare leaders. We would like to get it to the staffs and other people within healthcare, within the healthcare industry. That's why I'm really excited to continue to give you an update on this and to announce that our sponsor has agreed to give $1,000 for every 100 new YouTube or podcast subscribers through episode 31. And this is episode 22 to Hope Builders. Hope Builders is an organization in Orange County that provides life skills and job trainings to disadvantaged youth and gives them enduring professional and personal skills to put them on the right path. I've hired some of their graduates. It's a great program. Their stories are inspiring. They're incredible. We hope that you join us in sharing the show with your peers, your friends, to maximize this opportunity. And again, to just give you an update, we've already raised $1,000 over the last 3 weeks, but I'd like to push that number much higher. So today's guest is coming back for the second time, so that's a good thing. Today's guest is the original recovering CIO. If you go to recoveringcio.com, you will find his website. Former CIO for Scripps, Seattle Children's, among others. Now an independent consultant with who helps providers and startups across the spectrum. My good friend Drex DeFord is in the building. Good morning, Drex, and welcome back.
How are you?
I'm doing pretty good. How are you doing?
I'm doing good. I just came off some travel yesterday, so it's nice to be home in Seattle.
Yeah, I noticed that somebody did a Twitter post about the recovering CIO and gave you credit for being the first one to coin the term, and it literally you got the URL. recoveringcio.com takes you to your organization's website. How'd you come up with that? I mean, was that after your last CIO gig or after? Because you've done 2 or 3.
Yeah, I'm absolutely sure in the sort of mode of plagiarism is the most sincere form of flattery thinking, that I probably stole that from somebody in the past, and I don't know that I can necessarily say who, but I have had a GoDaddy account for a long time. So when I find a really cool or interesting phrase, I very often wind up grabbing the domain just to see if something happens with it. So that's one of those domains that auto forward.
Yeah.
Data hippie, nerdherder.com, all of those forward to my domain.
I'm a little bit of an addict as well. I'm curious what your GoDaddy bill is up to annually. I think I literally have about 15 to 20 domains that I've collected over the years.
I'm probably in the same boat. I have a few, and I let a few go every year where I'm like, okay, that one's never going anywhere. So.
That was a good idea back in 1998, and maybe not so much anymore.
Yeah.
So,
hard to find good ones.
Yeah. Oh, absolutely. So one of the things we like to do is just give our guests a couple minutes to tell us, what you're working on, what you're excited about today. So what's going on in your world?
Yeah, So I just came back off of travel down to the Synergies board meeting. Synergies, of course, best-in-class healthcare security consulting firm based in Austin. We met in Southern California yesterday, a board meeting. So I'm on the board of directors of Synergies, which actually has been a massive, super cool learning opportunity, publicly traded company on the New York Stock Exchange. We rang the bell on the podium a couple of years ago, which isn't one of those things you can really put on your list to do. It just has to sort of happen to you. So we've been through some M&A. We've done a bunch of stuff. I've learned a ton being on that board of directors. So that's been really great. Other than that, I'm working on the usual sort of stuff with health systems around strategy and planning, lean operations, implementation kind of stuff. I still do a lot of work with vendors. I have retainers with a few vendors helping with everything from sales training to product development to, you name it, marketing, right on down the line. I still do some work with VCs and PE firms from time to time. I'm thrashing through a book right now and that I don't know if it will ever actually be finished or if it's just going to be this always pending draft document in my Microsoft Word folder. But can I curse? The name of the book is You Can't Bullshit an Old Bullshitter. So we got to see how that comes out. And in the spirit of space nerd, I continue to stay plugged into NASA and SpaceX and Blue Origin and all of that, as we talked about last time. So love the space station stuff.
Big announcement from NASA today on findings on Mars. 3 billion year old. Oh gosh, I didn't. I'm sorry. I read it like a half hour before the show. Like 3 billion year old findings of matter, as well as they believe there's matter on Mars that can support the elements that would be required to support life. So it'll be interesting. Obviously, that's, if you and I were independently wealthy, that's where we'd be spending our time.
Oh, for sure. I would definitely be a space tourist. That's no doubt.
Yeah, it is. It is so much fun. And one of the things we don't probably talk enough about on this show is security. And if anyone wants to know why, the reason is we have a lot of CIOs, either former or current, and most of them are under strict guidance from their security firms not to talk about their security posture publicly, because half the battle for somebody trying to hack in is just picking up sound bites. And so anytime we go to talk about security, CIOs are a little leery to do that because you just don't want to. You don't want to make it easy for somebody, so you don't want to talk about, we have a 3-tier architecture and we're doing this, we're doing that.
Yeah, for sure. You give away a lot of stuff just accidentally when you talk about it. So yeah, that's probably for the best.
Yeah, absolutely. So I'll transition here. So on our show, we do 3 things. We do In the News, Sound Bites, and Social Media Close. In the News, we each pick a story, and you picked the story for the week. So I'm going to let you go ahead and kick it off with your story. Give us a little background and we'll go back and forth on it.
Sure. So kind of the story of the week, the Worldwide Developers Conference in San Jose, the Apple Worldwide Developers Conference in San Jose this week, announced a bunch of different cool and interesting stuff, as they always do. But in particular, they announced that they're making the Health Records API available to developers and medical researchers. And I'm reading this from the website, or it's not from the Apple website. It's actually coming from Health Data Management. Thanks, guys, for writing this up. Help consumers better manage their medications, nutrition plans, and diagnose diseases. So, I find this really interesting because we have gone through a long period of time. Google's tried to build a personal health record and basically bailed on it. Microsoft has a personal health record, Health Vault, still not used extensively in this country, but is used in other countries. And so this kind of whole new approach of how do you create a personal health record, but maybe the foundation of the record is on your phone and you control it and manage it. And with the release of these APIs, the ability for other developers to be able to connect to that health records app and do other cool and interesting things that might ultimately drive you to stay more healthy and be more healthy is a really interesting idea. I'm concerned about a lot of things, as a lot of people are, always about security. I always have security and privacy in the back of my mind, but the opportunities there are pretty cool, and it'll be interesting to see what health systems and vendors come up with.
So around security, one of the things they noted is the health record data is encrypted, which we already know, on the phone. and protected with the consumer's passcode and that technology. But they also emphasized, and this was something I did not, I knew they would have to address it. I didn't know how they were going to do it. So that the data flows directly from Apple's Health Kit to the third-party apps, and that it is not sent to the vendor servers. So it's not a mechanism for like a Facebook, like, oh, I have access to this information now. I can just suck all this data out from this patient and move it to our servers and start selling the data. That's not how this is designed. It just goes, it stays on the phone. It goes from HealthKit to that vendor's app, gets used there, and obviously with cloud services, and then gets put right back where it was. So that's one of the things I found interesting about how they're going to do security.
Yeah. The devil's in the details. I mean, I really want to see and understand how that actually works. But the idea that ultimately we're creating this system where you are in control of your data and you can release what data you want to whoever you want is a really good privacy strategy. I get to manage my data the way I want to manage my data, and no one else has access to it. If that's ultimately what this really boils down to, I'm in. I think that's a good strategy.
Yeah, and it looks like a lot of the rest of the industry's in. So in this article, John Halamka, guest on the show, as these API tools become more widely available, smartphones will be increasingly important middleware component that enables patients to be stewards of their own data. Stan Huff, Chief Medical Informatics Officer at Intermountain Healthcare, describes Apple's initiatives as exciting and pivotal, given the fact that the company is supporting HL7 Fire APIs. Robert Wachter, who wrote the book Digital Doctor, is also very positive. Karen DeSalvo is very positive. And actually, I'm going to focus in on two of these. So Ken Mandel of SMART and SMART on Fire fame, Director of Computational Health Informatics Program at Boston Children's Hospital, someone who I had come out to California and speak to our physicians on the value of interoperability within healthcare. Great guy, extremely smart. Observes that Apple has taken the next logical step in creating a health apps economy. And I think that's what we're all really excited about. He goes on to say, by connecting to hundreds of electronic health record systems using the open SMART on Fire API standards, Apple has committed to and advanced the interoperability of health data across vendors and organizations. With this announcement, they are opening up the key health system data to their iOS development community, who will soon have access to blood counts and medications for apps, just as they have access to calendar, contacts, locations, and step count. And I think he hits the nail on the head. I mean, we're creating a health app economy. When a developer used to have to develop an app, they have to decide, how are they going to interface with the EHR? We all know there's 100 different EHRs. Are they going to, go through a third party, an API? Are they going to go directly through a like an app orchard or something to that effect? And now you have this mechanism where they can, at least with the data they have, and now it's not great data, and that's the next thing I wanted to sort of touch on with you. But they've created this health app economy. Do you think we're going to see an explosion, like just a huge number of apps come out on top of this? I mean, we're talking about, I think 400 or 500 hospitals at this point that have connected in.
Record. Yeah.
Do you think we're going to see an explosion of apps on this, or is it going to be slow?
So I think what we see in the App Store in a lot of cases when it comes to quantified self and personal health kind of applications, there are a lot of people that download them and use them once or twice, and they're not sticky, or they don't do the thing that the person kind of hoped that they would do or wanted them to do. And so when it comes back to sort of average daily user count for those applications, there's lots of them, but lots of them that aren't used. So really very few of them are used. I think we'll probably go through a similar cycle with this. I think there's a couple of paths here, right? And I don't know that the electronic health record vendors are going to maybe like this idea very much, but I think the idea of the electronic health record on the consumer side, on the customer side, and you heard me rant and rave about we really shouldn't talk about them as patients, they really are customers. On the consumer side, on the customer side, I think we're going to see this path where they're going to get better access to their records, the data in their records, and then using apps that we're going to have a lot of developers are going to have to struggle through this to figure out what really works and what doesn't work. But ultimately, they're going to be able to see their data in different ways that works for them, given that we're all individuals and we all have different ways of wanting to consume data. Sort of another version of personalized health, right? I'm going to be able to use an application that drives the data to me in the way that I need it, that leads me ultimately to live a better, more healthy lifestyle. That's one path that we're going to see. And the EHR vendors really in that scenario are just going to be the data repository for the data. I think there's going to be another version of this that happens on the provider side with Fire and APIs and lots of other things like that, not necessarily Apple, but there could be lots of ways that this will come about. I think you'll see the same thing. There are lots of, between transplant and lab and rad, and, we've all gone to, or many of us have gone to best of suite electronic health records. What if you could layer on top of that a bunch of applications that let you as a provider see data and use data the way that you really want to use it? And again, the EHR just becomes the underlying infrastructure, database infrastructure to feed those apps. It's an interesting idea, and I do play around with, where could this go and how could it work? And being here in Seattle, I work with a lot of startups and a lot of big thinkers. So it's fun to brainstorm through this. So I don't know if there will be an explosion of apps ultimately. I think there will be probably a lot of apps, and a lot of them will be left also to the side of the road over time as they develop and redevelop and redevelop. But that's the beauty of something like an app store or something that can be improved on over time. It's an iterative process. You find out the things that really work and the things that don't work, and you're not burdened with the giant legacy system that you've built to support it. That becomes somebody else's responsibility. Yep. In this case, the EHR vendors.
Yeah, and will there be an explosion? I believe we will see an uptick. We'll see an explosion probably 3 years out. A couple of hurdles we still need to get over. One is the EHR providers do not want to be relegated to a data transaction or a transactional processing system for the health systems. They do make money out of the APIs. At least one of the major vendors makes money out of their APIs. They, have gone on record, and normally, they've gone on record. At least the predominant EHR provider, their leader, has gone on record as saying, we need to protect the patients from themselves. Essentially, we give them this information. It's very complex. They might make the wrong decision. I understand the sentiment of that the health record is very complicated, and I wouldn't know what to do with my health record. But there's a whole bunch of brokers out there that could take my health record and give me a lot of insight into, my maladies or disease state or my proclivity to certain things that I think is valuable. Let me hit on this last one. So this is from someone you probably know pretty well, Eric Topol from Scripps. Wrote the book, The Patient Will See You Now, The Future of Medicine is in your hands, was also quoted in this. Maybe not as optimistic, a little guarded. Apple's continued effort to get patients accessibility to their medical data is laudable, says Topol. However, he adds that we are a long way from getting a holistic, comprehensive data, but this is a step in the right direction. And what he's talking about is, the challenge with the data itself. Intermountain's Huff, who's been an advocate for clinical data models and terminologies, says his only concern is that there's a need to further standardize the models and terminology used in fire services so that the industry ends up with true semantic interoperability across the marketplace. And you and I have, this is why we have less hair and gray hair, is, you start digging into these various disparate EHRs, and it's not so much that the EHRs store data differently or those kind of things, although they do. But really it is that we put it in differently. We put the same prescription in 5 different ways, and it's really the same thing. And even when I talk to people about AI models and are we going to be able to apply AI models to these things, they're like, that is one of the harder things to get through, is that these 5 things are the same thing. It's just, it's a very challenging model. So I guess the question we on this one is, okay, the Fire API is phenomenal. We're getting out the basic information from the Fire API. And I imagine that will continue to progress. But as we get into some of the more complex data sets and some of the unstructured data and whatnot, I would assume that's going to slow us down. Do you think that's going to slow down this progress? Or do you actually, let me rephrase this.
Okay.
Do you think there's going to be a push nationally to getting to that true clinical data model that just happens now that it's almost like we were going to try to get there so we can get to interoperability, but now that we're driving to interoperability, it might drive a standard data model across all these health systems. Do you see that happening, or what do you think is going to happen in this data model space?
Yeah. I regularly talk to clients too about sort of analytics in general and how to approach it. And so I'll tell you a short little story here, and maybe it kind of ties back into this. When I went to one of my health systems as the CIO, the data analysts were all sort of centered in the information services department. And so when my partners, clinical or business partners, wanted reports or databases or other things, they lined up outside the door, and there was a long line outside the door, and they would have a conversation with one of the analytics guys on my team, and they would gather the requirements, and they would build something in a spreadsheet and shake vigorously and give it back to the partner 2 weeks later. And by then the partner would say, now that I've thought more about it, maybe there's some other stuff I would like to have in there too. And the analysts would pull their hair out and go crazy and start over again. And we ultimately evolved that to a model where the analysts in the IS department were the folks who were they were sort of the consultants and the keepers of the data and the data governance. And we really pushed the actual analysis of the data to the front lines. We gave them Tableau or ClickView or something like that. And what happened was, instead of saying we're going to solve world hunger and build a data warehouse, we started off with, let's find 2 or 3 really hard chronic problems that we have in the health system and figure out the 23 data elements that we need to solve that. And what's the source of truth that we want to use for those 23 data elements from these 5 different systems? And let's build a database that pulls that data in on a regular basis, hourly, quarterly, weekly, whatever it actually takes to solve the problem. And then push the data visualization tools down to the frontline folks and let them figure out what's the best way for them to consume that data to change their business or clinical processes to ultimately drive better, faster, cheaper, safer, easier access care for patients and families. And when we did that, we sort of wound up going through a process where we accidentally but very intentionally went through a process of making decisions on, that's a really important data element, and we use it in lots of our decisions. So it's going to come from that system, and it's that data element. And now we're really going to go have conversations with the people who do the input of that data element to make sure that they understand why it's really important that they put in something from the drop-down menu, or that they actually answer the question, or we modified the system so that it made it really easy for you to answer that question instead of bypass it. So the things that we needed to make better business and clinical decisions drove the way that we ran the applications and the way that we trained the personnel that use the systems. Maybe there's something in that, in this larger sort of context, as far as we don't have to get it all right away. And maybe we shouldn't even try maybe what we should focus on are the data elements in our electronic health records and other systems that all taken together are the things that are the most important data elements that drive improvements in health for patients and families.
Yep, I love that. What I would say is that transparency changes things, right? So you give Tableau, ClickView to the frontline physicians who are trying to utilize the data. They get transparency into it. They look at it and they go, hey, this data is a mess. We should talk to that medical group. We should talk to those doctors.
That's right.
And I think that same thing is going to happen here. Transparency of the data nationally is going to get people to say, hey, you know what, at least for these things, we could handle, cancer moonshots better if the data was, better along certain lines. So I think we'll see that. To close out this story, the last thing I would say to people is this, this has left the barn. Get connected. First of all, get your EHR FHIR connectors set up. You should be done by now, actually. Contact Apple, get it involved in this, get connected, get your health system connected to it. This horse has left the barn. If you're not on board, you could be left behind. I think this is not a trend that's going to fail and come back. I think this is a trend that it might move slower than we think, but it's going to move. So
I agree. I think it's definitely going to move, and it may be a little slower and a little more cautionary. I mean, I think Apple's learned a lot from the other tech vendors who have said, "Oh, hey, we're going to solve healthcare," and then they get into healthcare, and then a year later or two, with their tail between their legs, they leave saying, "Oh man, that was super complicated. I had no idea what was actually happening in healthcare." They've been a little more cautious in their approach, but you're right. This is the barn is out the door. The horse is out of the barn door, as you say. So we're on our way.
That's the analogy we're looking for. Not that anyone understands what the horse is out of the barn means anymore, but we'll keep using it.
Okay.
So here's my story. So the headline is, "You'll be shocked at the price of healthcare for a family of four." It's from an MSN article. I think it was published yesterday. Here's a couple things from it. Healthcare costs have been increasing at the lowest rate in the past 2 decades. The result, the total cost of a typical family of four insured by the most common health plan offered by employers will average $28,166 this year, according to the Milliman Medical Index. The estimate includes average cost of health insurance paid by the employers and employee, as well as deductibles and out-of-pocket expenses. Despite the significant expense for many households and employers, the slower rate of growth is good news, says Scott Welts, a principal at the consulting actuary in Brookfield office of Milliman. My first question to you is, does that number surprise you? $28,166 a year for a typical family of four. Is anything surprising about that?
I think it's only surprising in that, when you see the number and you think about the amount of money that the average American makes, even at this point where we're at full employment, man, it's shocking. It's in some ways it's kind of horrifying that it costs this much, which signals to me there's still a massive amount of waste in healthcare. There's still a lot of consolidation to be done. We don't operate well, and you can't say that in every case when it comes to healthcare, but man, this is a huge amount of. Ultimately, people are making decisions, right, about are we going to pay the rent, are we going to buy food, or are we going to pay our healthcare premium? These are hard choices that most of the country are facing right now.
Yeah, and I've seen this from a lot of different angles. Obviously, CIO for a health system had 600 and some odd employees reporting into me, so I saw it from their perspective and from the health system P&L perspective. I now have also seen this from my perspective. So one of the things that they note in this is that the total cost includes the premiums paid by the employers. And I think that over the last 2 years was the first time I've had 3 consulting practices. The first 2 were just Bill Russell Inc. This one I've actually hired a team. So I have employees, we have insurance. So I went out and had to, buy insurance and get it all set up and that kind of stuff. That was eye-opening to me. It was really eye-opening how, I thought we'd be able to go online, select, sort of like the Geico experience. That's just not the case. I ended up with filling out this almost looked like identical forms for 3 different carriers, one for dental, one for medical, vision was a different one. And, I'm working with a broker. I'm like, can you do this stuff online? They're like, well, in a couple years, we'll be able to do this. And
Right.
I'm looking at that and I'm going, all right, well, I could see the waste is right in front of me. I mean, I'm sitting here with, 15 to 18 pieces of paper I have to fill out. There's the waste in and of itself.
Yeah.
Then you talk, just knowing what we know about billing, the average medical bill has to be sent out or generated 12 times before it actually gets paid. Well, name another industry that we generate a bill 12 times before we get paid. It just, it doesn't exist. So there's still so much to do. I want to transition this to really our listeners on this show. Health systems continue to be under pressure for cost reductions. IT remains one of the largest sources of cost. What are some strategies that you've done to contain or reduce IT costs in the past, and what do you think the CIO should be doing now?
So for me, that was every time I came into a CIO job, it was a turnaround thing, which may just be obvious, right? There are times that you wind up in a new CIO job where the previous CIO had simply decided to retire, or they've been recruited away to another place. Very often, though, it's a different situation. You have to come in and fix a lot of stuff. Often that also ties back to cost pressures. So for me, when I went to Seattle Children's, it was, for me, part of the reason I went was Lean and Toyota Production Systems. It was a cultural way of making decisions about how they were going to prioritize the work they were going to do, but also driving that sort of take waste out every day, 1 second at a time kind of approach. That really did allow the organization to become more efficient and more cost-effective, kind of 1 drop at a time. So practice. I'm a huge fan of Lean.
Practicing Lean, like our health system did it system-wide, but if a CIO is in a health system that's not doing Lean, how do they get started? Where would you direct them?
Yeah, so there's a couple of things that every place that I go that these are just 2 of the things you can do and take some waste out of the process at the same time. One of them is to do a daily huddle and maybe do a daily huddle and do away with the weekly or the every other week staff meeting that you have. Everybody shows up, you've got 20, 25 minutes, 15 minutes, whatever it turns out to be. And you literally go through a process of having a conversation about what are we doing today? What are the roadblocks for getting those things done? How do we overcome them? There's usually a list of things that are ongoing, pending, challenging issues that you can talk about. You can talk about a safety item or something like that. But the beauty of this is that you understand every day where you're at today, instead of having a conversation once a week where somebody has been saving up stuff for a week and they're mad and frustrated and, then they barf all over the table, and that's not good for anybody. So doing daily huddles and really understanding where you're at every day, where the issues are, every day, every morning, so that you can work them makes a great amount of sense, not just for the CIO, but their direct reports, their managers and directors should be doing daily huddles with their teams too. The other one is going to Gembo, going to the place where the work is done, whether that means the CIO or the directors or the managers going actually out into clinics or business operations and seeing how the work is done to better understand how their delivery of healthcare IT solutions makes it easier or harder for those partners to deliver great care to our patients and families, Or sometimes it comes down to me sitting down with 3 analysts in, one of the areas of the department and talking about some process that they're working on. It was not unusual for me to go in and sit down and pick out one particular thing and talk to an analyst on one day who drew out a diagram of how that process worked, and then go back the next day and talk to the next analyst about the same process who drew out a diagram on how the process worked, and then getting the 2 or 3 of them together and showing them the diagrams and having them have the revelation of, man, why are we doing this 3 different ways? We should just agree on one way and then we can all do it. And then I can go on vacation and you won't call me because there's some weird thing that I'm doing that we're not doing as a team. And when you develop that culture, ultimately you can drive that thinking down into the organization. And this idea of, I'm unique and special to the health system, and the reason that I'm valuable is that I know stuff that nobody else knows, starts to change to creating good standard work that allows everybody to be more effective than they've ever been before is the reason that I'm valuable to this health system. So it's, lean to me it is a big deal, and I understand it's kind of magical for a lot of people. I know sometimes it's kind of just a management term that people use, but it's a real cultural approach, and it can really make a difference in how your employees engage in your health system. It can make a real difference in saving money. It can make a real difference in how well you care for patients and families. So obviously I'm a fan. I've lived in Japan. I lived in Japan for 3.5 years. I've been back since to, meet with Yamaha and Toyota. And so, yeah, I've drank the Kool-Aid. I'm that guy.
Yeah, it's good stuff. So our organization had lean methodology across the board, and drove out millions in waste and cost and improved safety. In IT, we took a sort of a modified lean / agile, visible management, stand-up huddles, those kinds of things. All of our major projects had stand-up and visual. So every one of our walls within our IT building
visual,
had something I could just walk by and look at and say, hey, I've got a question, what's going on? And because you're doing daily stand-ups, it's not hard to find somebody who knows what's going on. And yeah, we talked about that this morning. Here's what's going on. And I'll tell you the other thing that I'll give IT organizations one thing they can implement, which is when we sat down, we had 120 projects going, and I decided I'm going to bring all my my direct reports into a room, and every one of the project managers was going to come in, and they just had to tell us, give us an idea of how the project originated, what problem is it trying to solve, does the problem still exist today, and where you're at and what you need from management to be successful. And the first meeting almost took a day and a half, all 120 projects to go through them. But when we were done, we cut out like 20 projects because the problem that existed at one point did not exist anymore. And we still had IT resources allocated to it. We were still, generating documents, doing all sorts of stuff. And it was nuts. And we just and that's, it's just lean. It's logic. It's not necessarily lean per se, but it's just logic to say, hey, you know what? Let's continue to ask the question of, do we still need to be doing this work in this way with the changes that have happened? So.
Yeah. One of the things in lean is the 5 whys. You ask for anything that's going on, you ask why 5 times, and you'll probably really get to the root problem after the 5th answer. This idea of, being able to see into your organization and understand what you're doing. Many healthcare organizations, it's again a big part of what I do, don't have great governance processes when it comes to deciding what projects they're going to do and what they're not going to do. They don't actively kind of draw a line and say, we're going to do the things above the line, and all of those things have business or clinical sponsors. These aren't IS projects, they're clinical projects or business projects. And the things below the line, we have as a group decided that we're not going to do, so we're going to actively not do those. And that means that our business and clinical leaders aren't going to have little black operations where they try to do those projects either. And if they do, they get in trouble for trying to do that. So that, having good governance processes, understanding where all your contracts are. Do you actually have all of your contracts? Most of the places I go into and have that conversation, it turns out that some significant number of contracts were signed by the CIO 2 CIOs ago, and they don't actually have the contract anymore somewhere in a file. They just are paying the bill. Right. So going through that legacy stuff, all the M&A stuff that's going on right now, right? You wind up with, even when it's not an M&A thing, you wind up with a multi-hospital system that very often buys 3 applications that all do almost the same thing. So this application rationalization effort that I know you work on too, let's pick one app and kill off the other 2, can save a lot of money and drive a lot of standard work and improve the data that we collect, right? So it has a whole bunch of secondary, tertiary positive impacts.
Yeah, we're going to do a whole show on M&A at some point. I went through one of the largest M&As in healthcare. Obviously, the 2 organizations come together, formed a $22 some odd billion health system. So eventually we'll get there. But I'm actually running over already. So here's what we're going to do. The second part of the show is we call sound bites. I'm going to give you 5 questions. You get 1 to 3 minutes to answer. And I'll cut you off if it goes too long. We'll start with the easy one. So kids are graduating from college. So if you had a kid going to college today, what's the major you would tell them to focus on if they were interested in healthcare IT?
Yeah. Analytics. I think it doesn't matter healthcare or not. I just think the idea that whether you're going to be an actual data analyst professionally, or you're going to be a business operator or a clinical operator in the front lines, you need to understand data and data analytics. And not just that, but also data visualization. I'm a big fan of Edward Tufte. I read and reread his stuff all the time. A picture is worth 1,000 words. If you can figure out how to show data in the right way, you can convince people to do the right thing, over and over and over again. There's some other companies that I work with that do some really awesome data visualization. Arcadia Health Solutions in Boston has a whole page on their website, a data gallery that has some amazing data visualization. So that idea of whatever it is, however you get into it, whether it's a major or a minor, you really need to understand data and how it works and at least the fundamentals of sort of database design and how you take that data and make it work for you.
Yep. And that's just the result that's digital, right? The exhaustive digital.
It is. It's just the world that we're in now, right? You have to know it and understand it. And it almost doesn't matter what job you're doing. You have to have a sound fundamental understanding of that capability.
Yep. So the raging role debate for healthcare technology leadership. So you have a CIO, some health systems have a chief digital officer, CDO,
right.
Some have a CIO, chief innovation officer, and so on. I guess my question is, who's the voice of the future for healthcare? Who is setting the course for the next 10 years of that group, or who do you think should be?
I think if I understand the question right, for me, the question is more of a question about where do you try to draw whatever the gray line is between strategy and tactics, right? So when it comes to job titles, if you're a chief information officer and you really focus on strategy and you have a really strong chief technology officer that keeps the trains running on time and does it efficiently and manages the budget really well and all of those kinds of things, then it doesn't matter. You can call it a chief information officer. I think we see a lot of health systems where there are strategic chief information officers who try to be strategic, but because the daily operations have regular challenges, they get sucked into the tactical side of the house on a regular basis. And that can cause some significant frustration for your executive peers, because the only thing you seem to be working on is that XYZ that isn't working well today. So those health systems go out and hire chief digital officers or chief innovation officers to think strategically and not be mired in daily tactical operations. So I don't know that necessarily makes a difference. You could call them purple. It doesn't really matter what the title is. I think the issue is where and how you draw the line between strategy and tactics. And then when it comes to strategy, really being involved with your business and clinical partners, developing new, better, creative, innovative ways to deliver care, great care to patients and families. And that isn't just a technology issue. That's a people and process and business and alliances and partnerships with other organizations. All that gets wrapped into it. I think those are the people who are ultimately going to help drive healthcare in the right direction in the future.
Yeah. I'll close that out by saying I think the leader of the digital strategy within the health system is the CEO, and no exception. So
yeah, that's right.
So what are one or two technologies that you're keeping an eye on right now that could be disruptive to healthcare? And, you know, let's just say the timeline is the next 5 years.
Yeah. So, I mean, I think because of many of the things that I write about and post about on Twitter, I have to say artificial intelligence. But artificial intelligence is one of those things that I think by the time we develop that thing that was artificial intelligence, by the time we get to it, we call it something else. So AI is always just out of reach. So we have Siri and we have Alexa and we have self-driving cars, and all those things at one point we would have described as artificial intelligence, but that's not really what they are now. You know, they're just a thing that we have and a thing that we use. And I think we see the same thing in healthcare when it comes to, you know, digital radiology and, you know, a whole bunch of other stuff. That's not artificial intelligence now. That's just a thing that we use. I think general artificial intelligence is a long ways off, although there's a lot of people doing a lot of cool stuff in labs around the world that don't talk about what they're doing. So I could be wrong with that, but I think AI ultimately could be and will be one of those things that will over time incrementally continue to allow us to use our time and our brains to work on the really hard stuff, because the stuff that can be automated or put into an artificial intelligence bucket, we're going to continue to march down that road. So AI is one.
I agree with you. I think AI and IoT are probably, for me, are 1 and 2, being able to monitor wherever they're at. I'm going to just keep going because we're running a little over here.
Out of time? Okay.
So the health IT job landscape continues to change. What do you tell the frontline staff about how to stay current with their skills? How can they, what should they be doing to stay current?
Yeah, you know, a few things. I mean, one is, if you can go to conferences and talk to your peers. That personal connection to other people, building that network. I mean, we live in a world now where it isn't what you know, it's that you have access to lots and lots of different people and things that can help you figure out those problems really quickly. So whether it's conferences or YouTube, I think there's a go out and get a certification, you know, kind of thing that also is really important, staying on top of it. I think there's other things too, like follow Bill on Twitter and listen to the show and play the show for your staff. Those are all things that kind of from a big industry perspective helps people stay in touch. And then I would say the other thing is it's not all about work. So go figure out other things that you like to do, that you're interested in, that helps keep your mind tuned up to think in the way that ultimately helps you at work. So for me, I mean, whether that's old cars or hiking or, you know, those are things that I do that cause me to think about how am I going to fix this problem with something that I can't just go to the store and buy. I have to sort of figure it out with the stuff that I have in this bucket, right? Or in my backpack. Yeah. That's good. That's a good model to drive improvement in your thinking processes around how do you solve problems at work.
Yeah, absolutely. And then, you know, last question, we hear a lot of leaders talking about cloud first strategy. What does a cloud first strategy mean, and why should a health system be thinking cloud first strategy?
like everything, cloud isn't a silver bullet. I mean, it's a new way to get services that we may have provided to ourselves in our data centers in the past. We're really risk averse in general in healthcare. So I think ultimately you have to look at what you are willing to let move to the cloud and find a way of working through that strategy at a pace that's right for you. Personally, I think you should hurry up. I think, we're kind of definitely in the going too slow mode right now, but whether it's a software as a service provider or putting your backups into the cloud or giving your research guys and ladies access to cloud services to support scaling up and scaling down research projects without buying the infrastructure, for your own data center, for your own property. All of those are good, maybe not business critical or clinical critical operations. If you kind of want to get started and figure out how to move, but I think it's mostly about moving. And then the other part is, and I go back to security and all of this, this is a new complicated architecture, right? You don't have this all in your data center now. So make sure that as you're thinking through this, think about what's your architecture going to look like and how are you going to connect these pieces together and protect them, and what's your incident response plan when something goes down. All of that is still important even as you move to the cloud.
Yeah, absolutely. I mean, I would disagree with you a little bit on that one.
Okay.
We're just different in terms of our risk posture. In 2011, I brought Box, Dropbox equivalent Box into the health system, and it enabled things that were not possible prior to that. There was nothing Microsoft offered in 2011 that even remotely got close to the amount of collaboration that happened in a secure, auditable environment. That's one aspect. When we moved to cloud infrastructure, we went from 2 to 3 weeks to provision a server to 2 minutes. When we went to DevOps, we went from 35 people running our DevOps or running our infrastructure to 5. I mean, there's a ton of cost savings and things, a bunch of agility that you can get to, a bunch of things that's why I built this. I built the company that I started around this cloud infrastructures, because I think the number one thing holding back healthcare is this thing called architecture, and I think we've allowed ourselves to, just a decade of this change, without an architect looking at all of them, and so we've ended up with this mess. And instead of saying we're going to purpose build this environment to be agile, nimble, cost effective, and efficient, and because we've done that, and we still think that that's the norm. We are way behind other industries, and we don't understand why we can't move faster. And I think the cloud is the first step to.
For sure, and I am with you there. I mean, not to do a commercial for you, but I think this is a great opportunity now.
This would be the second commercial you've done for me. I appreciate it.
So this would be a great opportunity for health systems to actually leapfrog a lot of the challenges that they have today, right? They could get over it if they were willing to go in a big way. They could leave a lot of the burdensome legacy. This is how we do things in the past, but it is a very scary thing for a lot of folks. But I think if you sit down and talk to somebody like you, and you really understand what you're doing and what the process can be and what's the timeline and what's it really going to cost and what's it really going to save, the scary part goes away, and it really becomes just a way to execute a very large project that ultimately saves you money, makes you way more efficient, makes you much more secure, makes you much more agile, all the things that you talked about. So I don't disagree with you. I think it's just our legacy of being risk averse keeps us from talking about something really different, even though it's probably less risky than what we're doing today.
Just so people know, we don't pay our guests for this show, but I really I really appreciate you saying that. So let's go ahead. Let's jump to the social media close. You have a post that you want to share?
Yeah, mine's kind of short and sweet here. If I can pull it up here real quick. It really it comes from Chrissy Farr on Twitter, and the tweet. I have a hard time finding it here. Anyway, she's been around for a really long time. She works at CNBC now. Living in Seattle, we'd love to keep an eye on Amazon and all the stuff that Amazon's doing, especially when it comes to healthcare. And so this article is largely about the stuff that's happening with 1492 or Amazon X, or it goes by a bunch of different names, and the work that they're doing in the background. It's not so much about the tweet or about this story. It's about for some people, it's a very interesting sort of pile of detective work that continues to go into figuring out how's Amazon ultimately going to plant their feet in healthcare, or are they going to plant their feet in healthcare? I think they have, they've been brilliant about dealing with customers. And if we really do take the approach that patients are customers, there's a lot we're going to be able to learn, or a lot that they're going to teach us, maybe with really hard lessons when they come into healthcare. Absolutely. So that's really what the story's about.
Yep, and no better company than Amazon in terms of their customer-centric culture to really take this thing forward. So my social media post is from our friend Sarah Richardson, who I guess interviewed you at HIMSS. And hers is on emotional intelligence. So Dwayne Casey was the NBA coach for the Toronto Raptors, I believe, and he was fired after not winning in the playoffs. After he was an NBA Coach of the Year. He was, really did a great job. I would encourage you to go out and look at it. The post is on. Again, look, Sarah Richardson under LinkedIn. It's an Inc.com article. And he wrote a letter to to Toronto, to the city of Toronto, thanking them, talking about how Toronto was good to his family, how it helped to really shape his thoughts and his thinking. And it's just that whole idea of emotional intelligence. There's so many meetings we walk out of that we're angry and upset and those kind of things, and we just need to be reminded over and over again that we're all on the same team. We're pulling in the same direction. So this was, if you want a great example of really marshaling your emotions and keeping your feet on the ground, this is a great post.
It's one of those things that when I read it, this is the thing that occurs to me is that Dwayne Casey's mom raised him right.
Yeah.
Right. He knows how to treat people, even when maybe things haven't gone the greatest. He was raised right.
Absolutely. So Drex, thanks for coming on the show. Tell people the best way to follow you.
You can follow me on Twitter at Drex DeFord, and of course connect with me on LinkedIn and send me an email anytime, drex@drex.io.
Awesome. You're giving out your email address. That's impressive.
For sure. I'll give you a phone number too if you want. Easy enough to find.
We're getting a lot of downloads for this podcast now. I'm not sure we want to give it out. Maybe. Follow me on Twitter, patients at the Patient CIO. The show This Week in HIT, website thisweekinhealthit.com. And if you want to see the videos, we're now up to over 150 videos. thisweekinhealthit.com/video. Once we get more followers, we'll get an actual vanity URL for our YouTube channel as well. Don't forget to share this with as many people as you can. We'd love to raise more money for Hope Builders. And please come back every Friday for more news, commentary, and information from industry influencers. That's all for now.